Welcome to this explainer. Today, we're unpacking the ultimate clinical reasoning framework for diagnosing dysphagia. You know, when a patient sits in front of you and says, "I can't swallow," it can feel like staring down this endless, totally overwhelming list of potential diseases. But today, we're going to transform that massive list into a simple, logical roadmap. By leveraging structured, physiological clues, we are going to become diagnostic detectives. Here's our roadmap for today. We'll cover the diagnostic approach, motility versus mechanical obstruction, causes and clues, compare achalasia and systemic sclerosis, choose the right investigations, and finally wrap it up with our clinical reasoning framework. Let's dive right in.
Section 1. The Dysphagia Diagnostic Approach. All right, so let's start with our core binary definition. Dysphagia, as we know, simply means difficulty swallowing. But fundamentally, every single case you see basically boils down to answering one simple question. Is the tube's motor broken, or is the tube itself physically blocked? It's literally that simple. It's either a motility disorder, where the esophagus just can't coordinate its movement, or it's a mechanical obstruction, meaning something is physically getting in the way.
Moving on to Section 2, motility versus mechanical obstruction.
Okay, this brings us to the primary fork in the road. And honestly, this is the single most important distinction in our entire diagnostic framework. You've got to ask the patient about their timeline with liquids versus solids. Think about the physics of swallowing for a second. Liquids are incredibly easy to swallow, right? So, if a patient tells you that both liquids and solids back up immediately, right from day one, well, the swallowing muscles themselves have failed. The propulsion system is completely broken. That's your motility disorder. But if they say solid food got stuck first, and then, maybe weeks or months later they started struggling with liquids, that means a physical roadblock is growing and progressively narrowing that lumen from the inside out.
I really want to pause here for a second because this is a massive clinical pearl. When you hear that progressive pattern, solids getting stuck first, followed by liquids down the line, that is a glaring, sirens blaring red flag. That pattern should immediately scream mechanical obstruction to you. And specifically, you've got to think esophageal cancer until proven otherwise. It absolutely demands an urgent investigation. No dragging our feet on this one.
Section 3. Common causes and clinical clues.
Next up, we need to populate those two main physiological pathways with the actual diseases we're going to encounter and the rapid-fire clues they leave behind. The patient's history practically hands you the diagnosis on a silver platter before you've even ordered a single test. For instance, if a patient has pain during swallowing, odynophagia, we're almost certainly dealing with inflammation or an infection like candidiasis. Or picture this, an elderly patient complains of regurgitating undigested food and has, well, terrible bad breath. That points straight to his Zenker's diverticulum, where food is literally rotting in an anatomical pouch. And if they have dysphagia accompanied by droopy eyelids, postosis, you're looking at a systemic neuromuscular issue like myasthenia gravis. The clues are all right there. You just have to listen for them.
Now, it's just as important to recognize what is not true organic dysphagia. If a patient feels a lump in their throat, but they have absolutely zero pain, zero weight loss, and no progressive difficulty with actual food, you should definitely consider globus sensation. This is a functional disorder, usually linked to anxiety. Spotting this early saves your patient from a lot of unnecessary invasive structural testing.
Section 4. Achalasia versus systemic sclerosis.
Let's pit two notorious motility disorders head-to-head. There is a fascinating physiological paradox between these two. Since they're both motility disorders, both cause trouble with solids and liquids right from the start. But the difference is all in the lower esophageal sphincter, the LES. Achalasia blocks food with this tightly clenched, high-pressure sphincter that just absolutely refuses to relax due to nerve damage. In stark contrast, systemic sclerosis features a floppy, weak, fibrotic sphincter with terribly low pressure. It's practically an open door, constantly inviting stomach acid to splash up. So one presents with a concrete wall, and the other with a totally incompetent barrier causing horrible reflux, yet both completely wreck normal esophageal movement.
Section 5. Choosing the right investigations.
With our suspects narrowed down, we shift from the history phase to the action phase. I want you to pause and think critically here. Which investigation is actually the most appropriate? In modern medicine, I know it's super tempting to just check every box and order the whole shebang, but a master clinician doesn't do that. You have to choose the specific test that proves the distinct physiological hypothesis you just built during your patient history. So, an upper GI endoscopy is almost always your first move. Why? Because you absolutely must rule out structural nightmares like cancer or strictures. But watch out, because here is the classic diagnostic trap. A perfectly normal-looking endoscopy does not mean the patient is fine. It just means there's no mechanical blockage. If that tube looks perfectly pink and wide open, but the patient still can't swallow, they probably have a motility disorder. That means you need to pivot and order esophageal manometry to actually measure the muscle pressures. Meanwhile, you'd use a barium swallow to watch the mechanics in real time and 24-hour pH monitoring when acid reflux is your prime suspect.
Finally, Section 6, the clinical reasoning framework.
Let's bring all this physiology together into a concrete, memorizable sequence. This right here is our master algorithm. 5 sequential steps that transform a messy, complicated patient history into a precise, targeted, and life-saving plan. Ready? Step 1. Identify the swallowing pattern, solids versus liquids, to decide between mechanical or motility. Step 2. Is it painful? If yes, think inflammation. Step 3. Are there alarm features like weight loss that demand an urgent cancer workup? Step 4. Sweep for associated clues, like that halitosis or ptosis we talked about. And finally, Step 5. Select the exact investigation that answers the physiological question you've just formulated.
If there is one core takeaway from this entire explainer, it is this. Brilliant clinicians use the patient's history to predict the diagnosis. They use medical tests purely for confirmation, never just for indiscriminate screening. Actually, if you follow the logic we've just laid out, the patient is effectively going to tell you exactly what's wrong with them within the first 5 minutes of conversation.
So I'm going to leave you with a provocative thought. The next time a patient sits down and tells you, "I can't swallow," are you going to just guess at random, or are you going to take this clear, step-by-step physiological framework directly into your next clinical shift to crack the case? Keep this diagnostic funnel in your mind, and you won't miss a thing. Thank you so much for joining me for this explainer, and as always, keep learning.